I would now like to welcome our first speaker of the day. The first speaker of the day is Donna Ludwinski, and her talk is entitled High Stakes, Difficult Choices, Navigating the Maze of Cancer Therapy. Making informed and strategic decisions about treatment creates a huge burden of responsibility for parents of children diagnosed with neuroblastoma. Information sources now range from oncologists and web-based medical journals to social media. The key elements of clinical research and perspectives on past, present and future therapies provide the context for understanding current advances in research. With mutual trust and respect in the doctor-parent relationship, informed parents are best equipped for the difficult task of making choices for their child. Welcome, Donna.
Thank you, Donna, excuse me, for that very kind introduction. And I sincerely appreciate the opportunity to be here. This is a very special day for the parents, and to have this in conjunction with the A&R meeting as well is an extraordinary way to do this, I think. And I'm very pleased to share with you today on this difficult topic. So my son, Eric, was diagnosed 25 years ago with high-risk neuroblastoma. He relapsed when he was 20 years old, and he went through almost 5 years of treatment, and he died 6 years ago. Since then, I've had opportunity to serve in various committees and advisories, and I currently manage the funded research programs at Solving Kids Cancer. I'd like to call out a certain organization in Chicago, the Children's Neuroblastoma Cancer Foundation, and Pat Tulungen, because she started doing parent education meetings, I think it's 16 years ago. I think the first one was in 2000. And she's had an extraordinary impact on families trying to learn about the current research, and has really paved the way for these types of meetings. So knowledge is of two kinds. We can know a subject ourselves, or we can know where to find information on it. So if we have knowledge, presumably we'll understand what our options are and we can make informed decisions. So what do we need to know? We need to know about the disease, we need to know about the treatment, and in order to understand it in terms of decision making, we need to understand the research process, and that involves statistics. So there are a lot of research on decision-making models, but most of them have to do with the physician and the patient, so presumably they're an adult. There's very little in the literature about parents with children with cancer making hard decisions. This was published in The Oncologist in 2012, and what they did is they took 4 models, starting with the paternalistic model, where the doctor has all the information and he decides for you, versus an informative model. I will give you facts, so I'll give you patient information, and then because of the empathy involved in that relationship, the doctor helps discern those facts and understand what the preferences is of the patient or the parent. And then, because there's sympathy in the relationship as well, the deliberative model involves hearing the doctor's preferences as well. So it's very much a shared decision-making process. And so their conclusion in this, and again, it's talking mostly about adults, but it says most clinicians underestimate the patient's desire to be involved in the decision-making process and assume that patients prefer a more paternalistic model of care. Well, interestingly, though, there's a trajectory over time. This isn't one moment in time, such as that diagnosis. There's a trajectory, so we will look at that. So you're making decisions about different things at different times. At diagnosis, ironically, it is a more paternalistic setting because there's a lack of understanding. There is a treatment path usually presented. There really isn't a lot of choices to make at that moment. At relapse, or in the case of refractory disease, lots of decisions are to be made, and it becomes far more difficult. And then, of course, the end-of-life decision-making that goes on is entirely different from the other two categories. And decision-making, of course, ranges from just the supportive care to off-the-shelf therapies or enrolling on a clinical trial. So there's a spectrum of parents and a spectrum of physicians, and there's different perspectives that come into play in terms of this interaction and making decisions together. Parents, obviously, their number one concern is cure, no question. They also want comprehensive information, usually, no stone unturned. They're concerned about the logistics, can they access, and how is that going to play out in their daily life, and then the quality of life for the child. Now, those concerns, the physician has those concerns as well, but often the quality of life is extremely important to the physician rather than just a headlong pursuit of cure. The physician also has ethical issues that sometimes surprise parents, because a physician cannot offer or suggest a therapy that is impossible for that family to access. So I've heard many times families say, well, why didn't the doctor mention that particular therapy? Well, they can't burden a family with something that they can't access. So that's why there's a focus on local options. And for the physicians that are actually doing the research, of course, they're also concerned about the quality of their research. So instead of the simple model of just the doctor and the patient, we have a more complicated arrangement, because we have a child that may be at a different age. I mean, the younger children have very little to say about treatment decisions. An older child may have a lot to say about that. Then there's the other category is the pressure on parents based on what they're learning from the outside, from their family and friends, from web sources, and then the parent community itself. Yesterday, one of the physicians who had given a talk was remarking on how unique the neuroblastoma parents are. And I've heard this for 25 years, that I really believe there is something different, but nobody knows what it is. Why are we different? I don't know. But that can create pressure on the parents for decision making, because it comes within that community. So ultimately, at the end of the day, we can't guarantee outcomes, but we certainly want to do the best we can in order to not deal with regret. In the literature, there's a lot of focus on regret in terms of decision making, and so that's one of the goals of even having this discussion. So the internet, I really think, is Pandora's box, and I can tell you firsthand that ignorance is bliss, because my son was diagnosed before the internet. And so I didn't know anything. I only knew what I was told at the hospital. There was no parent community, because I only knew 2 other families that had neuroblastoma. And I also didn't know the ramifications, late effects. There was so much I didn't know that it literally was a blissful time for the 13 years he was in remission. I also stayed away from, because the internet did come along, I stayed away from the information during that interim. The price to pay for knowledge is that it creates a great responsibility, and that can lead to regret. So making these decisions is a huge burden. And so looking at our different sources and then understanding the clinical research perspective, how this all works, is very important in terms of making informed decisions. And so the goal is to have mutual trust and respect. So that's a two-way relationship with the doctor and the parent. And in the end, the informed parents are best equipped to do this difficult task. So information varies in quality. And this is one of the issues that parents really can discuss and try to discern, but it's very difficult. And this is where talking to doctors about the degree of evidence in terms of certain information sources, there's some things that are solid. They're not debated. There is a consensus within the research community that is true. There's some things that there's evidence, but it's debated. There is no consensus. There's differing opinions. And then there's the flat out unknown. Don't really know what it is. There's not enough research that's done on it. So in stepping back and looking at neuroblastoma in relationship to all of cancer, many of you have probably heard of the Emperor of All Maladies. There was a PBS special done on it that's 6 hours, and I think it's very, very good. It's fascinating to think that, you know, for thousands of years, cancer was known as a problem, but the only way to treat it was to cut it out. And so finally, in the 40s, radiation started to be used, and then in the 60s, chemotherapy. And so we now live in a new era. You think of those thousands of years that have gone by. In this era, a lot of money and a lot of time has been spent to understand cancer, to know what causes it, and there have been some good conclusions made that early detection it makes a difference in outcomes. Smoking causes cancer, and understanding how it works. But what's interesting is those don't affect pediatric cancer. I mean, there's the smoking and early detection doesn't necessarily help with us. So in our this time period, we've now have the exploding fields of genomics and targeted drugs, new technologies, and immunotherapy, and you'll be hearing about that shortly from Dr. Maris. So a lot of parents don't like this statement, neuroblastoma is rare, because they want awareness to be proclaimed. They want people to understand this is a problem. It's a killer. It is a bad disease. But it is so incredibly rare that I wanted to show you visually how rare it is. So there's over 200 kinds of cancer, and 4 of them make up 50% of all cancers. That's breast, lung, prostate, and colon cancer. So that's the top line. That's 100 circles right there. Neuroblastoma, all pediatric cancers only account for 1% of all cancers. So that's this circle. And that little tiny wedge is the 7% that is neuroblastoma. And this one shows how, if you took that whole circle and broke it up, you can see all the different types of pediatric cancers. So we're looking at really, really, really small numbers. So you can imagine that creates a whole new difficulty to study if you have so few numbers. So in PubMed, I was looking at the number of publications over time, and in 1945 there was only 1 per year starting there, and as you go through the years to 2015, there were almost 1,400 publications. That's a lot of activity just on neuroblastoma. You can see that this article here was when it was first named, and that was in 1910. And it's interesting, in the quote, it says, the fact that 5 of the new cases have been recognized within a year seems to show that neurocytoma, which was one of the names proposed for neuroblastoma, is not a very rare tumor, and that tumors of this kind will be found to constitute an important group. So in 1962, there was an article that said, I thought this was interesting, on the heels of A&R, which is a really good meeting, it says there are few neoplasms of childhood which provide as much speculation as the neuroblastoma. And he says, even compared to leukemia, it says it produces no more animated or sometimes critical discussion at medical society meetings. So back in 1962, it was so interesting. Very little was truly understood about the disease, but it was an interesting disease. And you can see they talked about the prognosis in 1962. Out of 236 patients, there were 28 surviving over 5 years. So that's about 10%. And of course, we know those were probably low or intermediate risk. So no high risk. So this kind of shows you the interest in neuroblastoma within the research community. If you look at the incidence of neuroblastoma and rhabdomyosarcoma and Ewing sarcoma, and then look at the publications in 1 year, so that's annual incidence and annual publications, look at how many more publications there are on neuroblastoma than those other tumor types. But with all this information, parents have a problem because we can't discern. It's difficult, not being medical professionals, to discern what's good information and what's bad. So the disease was actually first described in the 1800s and then named, as I said, in 1910. And Dr. Audrey Evans was the first one to develop a staging system in the 70s. And then Garrett Brodeur and Fred Schwab worked on the discovering the MYC and amplification in the 80s, and then a lot of advances followed with with therapies and more understanding of the disease. A little bit of trivia about Dr. Berger, I found out that he is the only one who has been to every A&R meeting. And he says he's got a lot left. So you can see with the rare numbers and the amount of effort that's going into understanding this disease, how to treat it, international collaboration is absolutely essential. So over the years, there has been a concentrated effort to agree and come to a consensus on how to define the risk groups, and that required a staging system. And then if you're going to look at responses in trials, you have to look at the responses the same way. So there's an update on the International Neuroblastoma Response Criteria. So this is Dr. Andy Pearson, who was honored last night, and he was a key leader in this effort. So the goal was to define the risk groups precisely and then report outcomes consistently. And there are over 11, I didn't update this, it's quite a bit more than 11,000 in the patient records now. So, as you know, one of the reasons why neuroblastoma is so interesting is because it's so heterogeneous. You have low risk disease and intermediate risk disease accounting for about half of all neuroblastomas, and then the high risk disease the other half, and a huge discrepancy in their outcomes. So the treatment path is usually defined at diagnosis, which is good, but for refractory disease and for relapse disease, it's usually not. And that's where the parent decision-making becomes so difficult. Now, there are efforts to define that path ongoing. So high-risk neuroblastoma starts with, it has 3 chunks of treatment. So the induction is the chemotherapy and surgery, and the whole idea is to debulk, get rid of the disease that you can detect. The consolidation is to get rid of what you can't detect, and so that involves transplant and radiation, and then a post-consolidation phase, because so many still will relapse after that, is why we have the differentiating agents and immunotherapy. Now, that's for a diagnosis, but what if you're, what does it look like if you try to make a path that includes relapse and refractory? Well, we started trying to look at all the different twisty-turny directions you can go, and obviously it gets very complicated, and that's why decision-making gets difficult. Okay, so how is clinical research conducted? On the history of clinical trials, this is a very abbreviated history. Almost every article on it starts out with, it's 605 BC, Daniel and his friends said, hey, we'll eat water and vegetables and not the king's meat and wine, and check us out after 10 days. If we look good, we're good. And so that was the first. I don't think they thought it was a clinical trial, but that's the first one. So then you have surgeons on the field treating wounds in wartime using boiling oil or egg yolk, turpentine, and rosewater. You have, of course, learning about how to prevent scurvy in the sailors was a very significant advance. And then in 1943 was the first double-blinded controlled trial that was for the common cold, and it took place in England. So the challenges in clinical research arise from the fact that you're doing experiments on people. So there has to be some significant understanding of what are the scientific issues, what are the ethical issues, and what are the regulatory issues. So there are some international agreements that define how you can experiment on humans. And of course, there's this balancing act between the progress and the patient safety. So these elements are what goes into defining how you could do clinical research. The stages of research start with basic science, and that's always performed without necessarily a thought for practical ends. You're learning something new. You might learn something about the cancer cell or conceive of new ideas of how to attack it. In the translational era, then you're applying those discoveries, and you're trying to make agents in the lab, and then you're testing those in cell lines and mice. And then the clinical research is patient-oriented. So most agents are tested, as you know, in adults first, and then they're tested in children. So if you look at that entire trajectory, you start out with the preclinical lab work of something that looks promising, and then the very first step in children would be doing a phase 1 that's looking at dose and toxicity. These are usually smaller trials, often 20 or in that range, 20 or 30. And a lot of times they'll include multiple tumor types because they're not really looking at efficacy. They're not necessarily asking the question if it works. They're just trying to figure out how much you can give and is it toxic. The next phase is looking at efficacy. If you see a signal in the phase 1, then you take it to phase 2. These are usually bigger. They're still in relapse and refractory patients, and they also, they're usually the same tumor type. Sometimes phase 2 are multiple tumor types, but they divide them up into cohorts. And then if it looks like there's a good response and it looks promising, then it could be considered for a phase 3, which are very big, very expensive, very time consuming. And that is now put into first line therapy for newly diagnosed to compare if the existing treatments are better or the new treatment. If it works, now you have a new standard treatment. So this process, if starting with a single trial, when you plan the trial, conduct it and collect the data, analyze the data, report the results at meetings, publish the results, and that's not necessary, but it's a good thing to do, and then get regulatory approval, like in the case of the Unituxin antibody. This process took 20 years. So it's a very lengthy process. So there's a lot of tenacity that goes into the researchers to stick with that. So the trial design is focused on endpoints because that's the thing that you're going to measure. You can't do a trial and just say, let's see what happens. You have to define the endpoints, and then that's the thing that you're going to measure. So it's powered for the primary endpoints. Secondary endpoints are things to look at in addition, but it's not empowered to tell if that's true or false. So in phase 1, again, the dose and toxicity is looked at, so that's usually an endpoint. In phase 2, the tumor response is an endpoint, and usually, since they're relapse, it's overall response rate, which is where you combine your complete responses and partial responses, CR and PR, so that you can talk about a certain percentage responded. Notice that that doesn't tell you overall survival necessarily, but some phase 2 will look at progression-free survival. So how long can you be on the therapy before the tumor starts growing again? In phase 3, the endpoint is to improve survival, so you're looking at event-free survival and overall survival. The events are relapse or death or anything that has a significant impact. So as families going into cancer treatment, we work backwards. We start out with a phase 3 because that's we're newly diagnosed. So we go on, if there is one that's open, that's the trial you go on. Then for phase 2, for relapse and refractory, usually it's a salvage. Now often they'll do an off-study salvage before looking at phase 2 studies, but sometimes you go immediately on a phase 2 study for salvage. And then phase 1 is for when those are not working and you're trying new agents, but nobody knows if it works. And this is another way to look at it, how you step down through that process. So if you go on the NIH listing today and look for high-risk neuroblastoma protocols, there is one open phase 3 study that is for frontline, and that's the one in Europe. There are 51 phase 2 and 52 phase 1. And of course, these change all the time because they're opening and closing. And so within the phase 3, because there's a randomization that's going on, they're looking at the standard versus something new. There's usually 2 or more arms. The computer assigns the patients, and the point of that is to make sure that the 2 groups are well matched. So you want to have the same number of prognostic factors, age, and other factors so that you know the 2 groups are the same. There are a couple of different kinds of phase 3 trials. There are open versus blinded studies, and most of the pediatric cancer trials are open. In an open study, everyone knows what the treatment is if the child's getting it. In a blinded study, the patient or the family doesn't know, and because they might be getting a placebo. In a double-blinded study, the doctor doesn't know. So these are not often done, and you can probably imagine why. Although I found one recently, I was so surprised. I thought I had found every phase 3 study ever done in neuroblastoma, and I found this recently. It was published in the year 2000. It ran through the 90s and enrolled 175 patients. And they did a double-blind study of cis-retinoic acid, but the dosing was different because you would know, anyone whose child has had that agent knows if they're getting it. So what they did is they gave a very small dose continuously for 4 years, or placebo to the other group. So what happened? There was no difference between the two. They had 88 on the retinoic acid and 87 on the placebo. Now here's an interesting thing to look at. How many patients do you think finished the 4 years? Only 9 on the placebo and only 7 on the cis-retinoic acid. So very few. They started with, almost 90 on each one. Very few actually finished the trial. So looking at the significance, and we're going to talk about that in a minute, is difficult. So the example of the phase 3 study that's open right now, and this is a massive study at a meeting, the PI of this study, she said at a meeting at SIOPEN that she was going to go in the Guinness Book of World Records because this is an amazing trial. 2,700 children, they're going to enroll in this. It's already been open for 14 years, and it's still going. It's in 19 countries and 115 hospitals, and these R's stand for the different randomizations. So they've already finished the first randomization, which was looking at does it really help to get GCSF between cycles of chemo? And what they found is, yes, it does, because it reduces fever and hospitalization. And then they looked at the transplant regimen, is CEM or Bumel better? And they found out that Bumel was better. So now the randomization for the antibody has changed, because before the Unituxin was proven to be effective in the COG, they were doing antibody versus no antibody. Then they changed it after it was proven, because they couldn't ethically continue to do that. They went on to look at antibody with or without low-dose IL-2 that's given subcutaneously. And then they also decided to take another look at the 10-day cycle for induction versus the 21-day. That was already studied, but it was toxic, and it was versus a different 21-day induction, and so they're looking at that again to see if it's better. And then lastly, the long-term infusion they're looking at for the antibody. So pilot trials are another kind of trial that children can go on for frontline, and these are mostly to check to see if the treatment is feasible. They do look at outcomes on those trials, but the idea is to roll it into a big phase 3. So recently there was one that was finished, and it was looking at including MIBG before transplant for children. So they enrolled 105 patients, and they did it in 23 hospitals. And the reason why they were looking at feasibility is because not every hospital has an MIBG room. So they had to figure out, is it feasible for these families to travel, and those things. And of course, they looked at response rates and adverse events as well. So in the phase 2 arena, there are a lot of studies going on. These can be single arm, just everyone gets the same thing, or they can be randomized with 2 or more arms. And there's, for example, you could get, there are vaccine trials, there's MIBG combination trials that are randomized. There recently randomized trial with the chimeric antibody and chemotherapy. That randomization's been stopped, the trial's continuing, but everybody's now going to get that combination, which was shown to be better. So the idea on these trials is to assess the response rate and decide what's the best salvage regimen. In phase 1, most of the consent forms will plainly state the patient may not benefit. That's not the point of the trial. And this is difficult for families because when we're making decisions, it's based on the hope that something might work, but there may not be evidence of that yet. So they have to make sure that they say that. They look at the toxicity, and like we said before, all comers are often on phase 1. And so some examples of this is the PD-1 antibody and T-cell CAR. Now, why don't we look at an endpoint of survival for phase 1 studies? Well, this is why. This is a really depressing graph. This shows 262 patients that were on phase 1 trials at the NCI. So they had solid tumors, different trials. They just looked at all of them. How did the children do? So you can see very poor outcome, and it's kind of a visual of why phase 1 studies are not looking at outcome. Now, of course, we always hope for something better, but this is why outcomes aren't necessarily an endpoint. So who's conducting this research? The cooperative groups, there are several of them. The COG, the SIOP in Europe, the GPOH in Germany is actually going to join SIOP, and then of course the group here in Australia and New Zealand, and there are others. So the recent focus of clinical trials has been for low and intermediate risk to reduce therapy, but for high risk, it was said many times, we're done intensifying. Well, it looked like intensifying helped with the tandem transplant, so that's now the new standard. So, there are ongoing questions about these different phases, about, what do you do about all these different parts of the therapy? So randomization is a struggle for some families to understand why is that even necessary? Why do we have to be randomized? The ethics of randomization rest on a concept called equipoise. And in equipoise, it means that the researchers really don't know what's best. They really do not believe that one is better than the other. And of course, the other difficulty with randomization is you can't randomize everything. There's too many moving pieces. The therapy is too complex, but you can identify certain things to be randomized and get answers. The other thing is some trials have produced negative results. From 2000 to 2006, there was a trial in the US looking at whether or not the stem cells should be purged before giving them back after transplant. So the idea sounds really good. There could be neuroblastoma that you can't see in the stem cells. If they take that out, then maybe that'll prevent relapse. Maybe that's one of the reasons why the children are relapsing. So this, you can imagine, is an expensive trial. They enrolled 489 children, and after everything was said and done, there was absolutely no difference in the outcome. So you'd think that's a negative outcome, but the point is they know now that expensive process doesn't have to be done, and it also wastes some of the stem cells. So now they know it's not necessary to do that, and here's what the overall survival looked like. You can see that the unpurged, there's no significant difference between those, but the unpurged is slightly above the other one. Okay, so this is just a snapshot of the phase 3 trials. In the top is Europe, and the bottom is the US, and it just shows how many questions have been asked since 1980 and where we're at now. So the current trial that we talked about, the SIOP trial is here, and then the next COG, which is going to be opening sometime soon, and is still being defined what that's going to look like. So that gives you the picture of how these therapies evolve and why we have the therapies we have today. So let's take a quick look at survival statistics, and this is, I think, one of the things I struggled with the most in reading literature and trying to figure out what does this mean. Without this, we really can't tell what's meaningful. So significance is the big question. You have to look at the sample sizes. Large numbers can show small differences, and so this is where you also want to look at the sample characteristics of the population. If you're looking at a single arm where there's no randomization, how can you match those populations to make sure that there's really a difference? So these are the questions you ask when you look at these curves. So let's look at these two curves. They look shockingly different. This one on the left has visually a much lower outcome. They both say event-free survival, but this one looks a lot better. Why is that? Well, for one thing, you have to look at the starting points. It's very important. This is all the children in the COG who were treated in these decades. These were children who were randomized after transplant. So they had already made it through induction. They already made it through transplant. They were still alive and disease-free at this point, and so that's why the curves are so much higher. So this is another way to look at this and why these graphs can be so different. If you started with 100 kids, and I just made these numbers up, and you did induction, and only half of them had a complete response or a very good partial response and went on to transplant, then these 50 kids with a PR, a partial response, stable disease, or progressive disease, they do something else. They don't continue on. So then you have 50 kids who went to transplant. Let's say there's a 5% treatment-related mortality or some other issue that prevented them from going on. So now you have 48 kids going into some sort of post-consolidation, maintenance type antibodies or other treatment. Now, what if you have 60% survival, which sounds really good on the graph? The problem is, if you look at how many kids are left, that's only 29 out of the original 100. So that's why these graphs look so different from those different starting points. So when you look at trying to prove something actually is working, you have to look at the censored data, which refers to the number that are at risk over time. You have to look at the probability or the p-value and the corresponding confidence interval. And I'm going to show you what those mean. Okay, this is a made-up graph, and it shows the little tick marks, and I'm sure you've seen lots of graphs with these little tick marks. This shows, the reason why those are there is because you don't have, let's say there's 100 kids on this trial. They don't all start on day one and go through the therapy at the exact same time so that you have the same follow-up. What really happens is a kid goes on and then another kid a month later and another kid a month later. I mean, it's spread out over time. So the follow-up is spread out over time. So each one of those is put on the graph individually. So this child right here has only been followed up 2 years. So the reason why that tick mark is there is that says you don't know what happens to that child from here on out, because we don't know yet. So if you have a lot of tick marks on this side of your graph, you don't know very much about this over here. If you have a lot of tick marks over here, then you have a lot of confidence of what this side of the graph looks like. So this shows you another, this is related. This isn't censored data, but this gives you an idea of how this affects. If you were looking at this and saying, is it getting better? Is neuroblastoma treatment getting better? You could see it's gradually going up, so that's good. You know, the blue line is the early 90s, the late 90s is yellow, you know, and so on and so forth. And look at these huge numbers. You got, you know, 1,500 in the latest on the top graph, going down to 400. But it looks like it's dropping down. Why is the red line dropping down below the gray line? Well, this has to do with the number that are being followed on that graph. We started with the red line with 1,484 patients. And by this point in time, 5 years later, there's only 370 that are still followed at that point. Now, did all the rest die or relapse? No, there's a many lost to follow-up. This is just saying this many are still being followed up. And for that group, this is the 60% were still alive, okay? But look what happens here. At 7 years, there's only 40 kids that are still being followed. So that's why this is not significant. There's really no information that you can discern from this because the numbers are so small. And here's another picture of how this affects how the graphs change over time. This graph was published in 2010 and showed the outcomes from the antibody, and you could see here, they put the, at 2 years, it was 66% and 46%, that's significant difference. But a few years later, an updated 4-year event-free was published. Now look at how different those graphs look. This is the same study. Why do the graphs look so different? Well, it's because they weren't followed up. Look how many kids were actually followed at the 4-year point in 2010 when this was published. It's only 15 and 10 on each arm. Not significant. That's too few kids to know what's really going on here. And by this point in time, notice all the censored marks are afterwards. So that means they're pretty confident what's going on here. The problem is, though, the numbers weren't big enough to show a difference at 4 years. So the end of the day, had they accrued another 100 kids on each arm, they could have said this is statistically significant. Problem is they didn't accrue enough to power it at the 4-year point. So it doesn't mean it didn't work. it means there aren't enough to know that to prove it. Okay, so let's talk about relapse for a minute. The goal of relapse trials is to discover agents that are active against relapse and refractory disease. And between the lines means the goal isn't to necessarily cure. The plan is to improve frontline therapies. That's why relapse trials are so important. Now, that doesn't mean that individually you can't work toward cure, but that's not the fundamental focus. So if you're looking at relapse or refractory trials, the NIH listing right now has over 100 trials, and about 50 have a relevance for this situation. And so there's lots of ideas being looked at, lots and lots of things going on, and you're going to hear more about that later today. But there's efforts ongoing to really try to discern if there's a rational treatment for relapse that the goal is to cure, and that is going to involve sequences of therapies, but it's very difficult to study this because it's like doing the frontline therapies. They're difficult to prove that one is better than another. And then I wanted to show you this graph. I've stared at this graph for so long. This is from the INRG database, and it has 2,266 patients on it, and they all relapse. And this shows the overall survival of relapse. And look how far it goes out. 13 years, 13 years. And we often hear that relapse is incurable, but it looks like some are cured, and the interesting thing is we don't even know what the therapy is. There's absolutely no information, from this graph. Now, the thing to note, though, this is all neuroblastomas. So there are relapse, intermediate, and low risk included in this, but those percentages are fairly small in terms of you're counting all the relapses. So we don't know the effect on these curves from that. I mean, I don't have the data to look at that, but clearly there are high-risk children surviving. The other thing that's kind of interesting about this is early events versus late events. They divided the line between events that happen before a year passes from diagnosis and after a year. And you could see that the early events are worse at first, but then they do better over time. And then the later events are worse over time. So how do we learn about the current trials? We're, obviously you talk to your doctor, you can look at trial listings, you can go to meetings, you can read the publications. If you go on PubMed and look at neuroblastoma and limit it to clinical trials, you can read clinical trial reports and try to discern how they determine what is, what's meaningful. In this search, if you look for open studies, 130 studies were found for neuroblastoma. Now that's for all, some are biology studies and other things too. But if you click on this little button that says on a map, it shows where the trials are. And of course you can see wherever the population is a little bit bigger, you're going to see more trials. And then if you want to click on this part of the world, you see that there aren't very many listed, which is a difficulty with a rare disease and not a lot. There's just not enough patients to do very much. So there's also the Australian Children's Cancer Clinical Trials Registry, and it has 5 trials open for neuroblastoma, and then the Clinical Trials Registry for all cancer types also has trials listed. So I want to finish with a very, very fast story about a friend of mine that I got to see on the way here. His name is Wyatt. He was diagnosed at 4 months old. And at first everybody said, no problem. It's probably low risk, probably intermediate risk. He's going to be fine. Well, then they found out he was NMIC amplified. So he, and he did have stage 4. So he started his induction. And this was at a well baby check. He was perfectly fine. 4-month well baby check. So he went through induction, and then they had a really hard time deciding about transplant. because he had his kidney function was bad. And so and the whole point of the story is the decision making that goes on here. They asked everyone, asked his doctor, the parents talked to doctors all over, asking, what do we do? Do we do transplant? I mean, he's so little, his kidney function's bad. Well, very difficult decision. They went with transplant, and he immediately had a catastrophic reaction. They're still not sure what it was, but he spent 22 days in ICU. His mom's an artist, and she drew this picture of him when he was in ICU. So then, after transplant, this poor kid could not eat. He just constantly threw up. Anything that went in his stomach, he threw up. So for 6 months, they kept saying, could we check this out? This doesn't seem right, So finally, they did analysis and figured out that he had a complete blockage in his intestines from the radiation. So they did surgery, and he started eating. It was great. So then, the mom becomes pregnant, and 9 months later, after finishing antibody therapy, he starts limping, and he can't use one of his arms. I don't remember which one. And so this is what they found on his brain. And so the doctor said, he's come through so much, and he's doing so great, but this is incurable. There is nothing we can do. We can do surgery, but it's going to be fatal. So the dad looks around. This was actually right after the surgery. A little sister was born 2 weeks before they found out about the brain relapse, and there he was shortly. That was like a week after surgery. He was wrestling with his brother 48 hours after surgery. He's an amazing kid. So what happened was they started talking to other parents and found a paper in PubMed on what Sloan Kettering does for these brain relapses. And so when he was 3 years old, he finished that protocol. And then the dad decided to pursue a vaccine in Kentucky. He only got 1 dose because he had a huge reaction, and he ended up he had such a bad allergic reaction, they said, okay, that's good, we're done. So now he is 8 years old, and he is doing great. So the whole point of this story is that, we're often told accurate information about the likely outcomes and the likelihood of certain responses, but you never know. I mean, amazing things happen. And my own doctor, my son's doctor, used to say, you never know. He'd always leave that thread of hope going. But at the end of the day, regardless of the outcome, the goal for shared decision making is just be able to say we did our best. So sure.